Hi guys, it's Shad again, and I'm here to teach the principles of physiology. Today we are going to be talking about the lungs and different mechanisms of how gas exchange occurs in the lungs, how our lungs work with breathing properly. We're going to talk a little bit about how oxygen and carbon dioxide are transported through the blood and how hemoglobin has an effect on that. And so, first, I would like to start by addressing how the lungs work and just the membranes that are associated in the lung and what we need to know about that. And so, first, let me draw up a picture here. So, let's get that a little bit wider. So, talking about the membranes of the lung here, let me draw out a little picture for us. Well, let's do this. Okay, so this is one side. Might have to just adjust this a little bit here, sorry. Almost there, I promise. There we go. All right. So this here is our lung. I'm going to call these two sacs I drew right here. I'll call them I don't know why that's not working. Call these two guys the alveolus. Those are the little air sacs that are at the end of the terminal bronchioles. So these pipes here that I drew, these like tube-looking things, those are the bronchioles. And those bring air in from when we breathe, and they help us to exhale air as well. On these bronchioles, they have a little layer of smooth muscle, which I'm going to draw with red here. Outside of, so this is what we call the pleural cavity in here. Right outside of it, we have our visceral pleura. Just going to draw that in green in contrast to our pleural cavity. So there's our visceral pleura. And then right outside of that, we have our parietal pleura. Draw that one in red here. So, like I said, the green here is our visceral pleura. And the red here is our parietal pleura. Now this is all important anatomy to know as I'm going through and talking about the rest of the lungs here. So we have our lungs. We've set up the stage to start talking about different things that are happening within the lungs. First of all, let's talk about why the lungs, they like to maintain a negative pressure ventilation. When I use that word negative pressure ventilation, this is typically how the lungs operate all by themselves. Negative pressure ventilation. The opposite of that is positive pressure ventilation. And when we talk about positive pressure ventilation, this is basically like forced respiration, where you'd be hooked up to a machine at a hospital and they're forcing air into your lungs because you can't breathe for yourself. Our lungs, when we breathe on our own, we undergo negative pressure ventilation. And there's a couple of mechanisms that are allowing our lungs to work through a negative pressure system. And so let me explain a couple of factors that go into helping the system maintain a negative pressure. So within our lungs, the air sacs we have are the alveolus, and these things will be increasing in diameter as air fills them. But one thing within, so as we breathe air in, this air typically introduces a high level of humidity in our lungs, and within these alveolus, we have water. Water builds up in the alveolus here, and when that happens, if you think about surface tension of water, right? So if we have a bunch of water, if we pour water on a counter, and it was just to stay on the counter there, right? So let me demonstrate. This is our little counter. Oh, let's choose a different color. So here's our counter. If we were to pour water on that counter, the water wouldn't lay flat across the counter like that, typically. Typically, it'll make like this little peaked up bubble where you can tell that the water is kind of aggregating in one area. Now, the water likes to do that because what's happening molecularly within a bunch of water molecules next to each other is they form hydrogen bonds with one another. So water forms hydrogen bonds with one another, and they form a shape that's thermodynamically favorable to maintain this hydrogen bonding system. And so water likes the hydrogen bond, and when it does that, we call that surface tension. So one thing that we have to explain is our lungs naturally want to collapse. And the question we'll try to answer here is, why do they naturally want to collapse? Well, one reason being is because water molecules within the alveolus will attract to one another, right? Or hydrogen bonds. And this creates the idea of surface tension in the lungs. So see the small little alveolus we have here. Let me redraw my water just a wee bit smaller there. Water here is wanting to form hydrogen bonds and clump up. When we form hydrogen bonds, and it's on the surface of our alveolus, right? When water begins to start forming hydrogen bonds with other molecules of water, this will begin to collapse the lung, the alveolus will condense and become tighter. Because if there's water all along the edges here, their natural tendency is to want a hydrogen bond and pull the water molecules closer to each other. With water sitting on the surface of the alveolus here, that water is just going to be pulled through hydrogen bonding towards the center, and that's one reason that the lungs naturally want to collapse. Another reason, it being that the lungs have elastin proteins. So, second reason is the lungs have elastin proteins. These elastin proteins sit outside here, and what they do is, here, let me draw some water in this alveolus. What they do is, elastin helps the lungs to be more elastic, which means the lung wants to get as small as possible. So these elastin proteins will compress the alveolus. They help to compress it. And as they help to compress it, the lung is becoming more elastic and therefore can become as small as possible. Think about a rubber band. If you have a rubber band in between two fingers and you stretch that rubber band out really far, when you let go, so I'm going to draw this so poorly, but here's my two fingers right here, and let's say that this orange thing is the rubber band, right? Now let's say we keep stretching that rubber band out, right? We stretch and we stretch and we stretch it out. Well, once it's become stretched out a lot, if we were to remove the fingers, pull our fingers away, that rubber band will collapse to a tinier form, right? So once the fingers are removed, that rubber band goes back to its tiny little ring that it was in before we had stretched it out with our fingers. And so elastin in the lungs has a similar effect. When the lungs are not being stretched, they want to be as tight and as small as it can be. So, to continue our, let's continue our discussion here. So that's why the lungs want to naturally collapse. This is an important principle of negative pressure ventilation. So now let me talk about some other things that help to maintain that negative pressure ventilation. So let's say that, so we talked about surface tension, and talked about how the lungs have elastin proteins. Now let's talk a little bit about the pressures that are maintained within the lungs themselves. So let's say our alveolus here. So let's think about flow of when we think about flow of anything going, when we talked about blood flow earlier, in my video series, we talked about how pressures were involved and radiuses were involved. Well, this R is equivalent to 1 over 1/4 of the radius, right? So for air to flow into the lungs, we can think of this relationship of the pressure of the lungs and the pressure of the atmosphere working in unison to either allow air to flow into the lungs or out of the lungs. And so I wanted to introduce these two equations because they help us to kind of think about, okay, well, if the radius of our lungs is really, really small, then what's going to happen to the airflow? When we condense our radius really, really, really small, meaning the lungs are collapsing in, air wants to flow out. If the radius, so when R is really small, air goes out of the lungs. When R is large, air wants to go into the lungs. So, yeah, that's important to understand. So we also can talk about another principle that in chemistry there is a certain term that helps us to understand this as well and how pressures work and partial pressures. It's called Boyle's law. So Boyle's law helps us to understand that as the volume of something, if the volume of gases within a space, the volume of that space increases, right? Then the pressure that the gas is creating within that space decreases. So, and then as the volume of the space where the gas is kept decreases, the pressure maintained within that space will increase. And so, for both of these examples, we're thinking about, for the first example, where the volume of the space is really large, and let's say for each of these examples we have 6 moles of gas. Well, if that volume is really large within that space, then the pressure is going to be smaller. Now let's say we have a really tiny box, really tiny volume, with the same number of molecules. Those molecules are closer together now, so the pressure will increase in that one. And so this kind of has to do the ratio of like where the gas, like how many collisions the gas are having to create pressure, how often they hit into one another. So if you have the same number of moles of gas within a large chamber as you do in a small, in the large chamber the pressure will be decreased, in the smaller chamber the pressure will increase. So now let's keep moving about our discussion about the lungs. So one thing that we can say here is we using that logic of Bohr's law, when we want so as the volume of our lungs decreases, as our alveolus decrease in their size, the pressure of the alveolus is going to increase. As the volume or the size of the alveolus increases, the pressure of the alveolus will decrease. And so I'm going to refer to everything here. Let's say out here, out in the air, the ATM, the atmospheric pressure is 0. Well, within the alveolus, the pressure within the alveolus, let's say ATM is equal to 0. If the pressure within the alveolus is -1, let's just say that's the pressure. According to according to what we know about how pressure works, if we want air to flow into the lungs using this flow rate equation here that we were talking about earlier, right? The flow. If we want air to flow into the lungs, if the atmospheric pressure is higher than the pressure inside of the lungs, then air will want to flow into the lungs. And so, in this example here where the ATM is 0 and our alveolar pressure is -1, I'm just going to say AP for alveolar pressure is equal to -1, then air flows into the lungs. So air flows in. Right? We have a positive flow in that case because if the pressure of the alveolus is 0, we subtract that from -1, then we get a positive number there. That means the flow rate will be in, and so we get air in the lungs. Now when the atmospheric pressure is equal to 0, and the alveolar pressure is equal to +1, then air flows out of the lungs. So if that turns to +1, air is going out of the lungs. And so these things are helpful to be thinking about when we're thinking about how air moves in and out of the lungs. I want to cover another concept. We call this concept Laplace's law. Laplace's law. And so Laplace's law states that pressure is equal to 2 times the amount of tension on the lungs divided by the radius. So, this is an important concept when we're trying to understand how, remember how we're talking about the surface tension that water has here and how it makes the lungs collapse and how the lungs naturally want to collapse? Well, Laplace's law can help us understand a little bit more why that happens. So the tension here can be represented by our the surface tension, right? And then the radius here is represented by how big our lungs are. If we have a big alveolus, then the radius is going to be bigger. So in order to create more pressure in the lungs, if you want, for this law, we'll just say, if you want the pressure of the lungs to increase, the most logical way for that to happen is for the radius of the lungs to decrease. And if we increase the pressure of the lungs, right, we're saying that outside the lungs we have an ATM of 0. Inside the lungs we have an increased pressure, so we're moving towards a more positive pressure, so we can say +1 here. If we want air to get out of the lungs, we must decrease the radius, right? And that makes sense. If we want air to get into the lungs, we must increase that radius. Now, when we're talking about this can become a problem. If we're talking about how water and elastin are working, they help the lungs to naturally collapse, right? So that helps us to get air out of the lungs, which is normal. It's normal to get air out of the lungs that way. But in order for the lungs to fill back up, we need a way to weaken that surface tension. Because if we don't weaken that surface tension, we run into the risk of the lungs collapsing. And so, in order to weaken that surface tension, we have to introduce into the lungs something that we call surfactant. The job of surfactant, so let me just draw a little picture up here. The job of surfactant is to weaken surface tension in the lungs. So surfactant is a detergent-like molecule. It is amphipathic, meaning it has a polar and non-polar region. And so, if we throw surfactant into the lungs, this is going to help eliminate a lot of, it's going to help to weaken surface tension. Because what surfactant does is it butts its polar head into the water, and it attracts water molecules towards it, and holds them apart with their nonpolar tails there. So it weakens surface tension. Now, when we weaken surface tension, going back to Laplace's law here, if the surface tension is weakened, the pressure also decreases. And so if the pressure is decreasing within our alveolar sacs here, then we can breathe air in. Because if our pressure decreases below the atmospheric pressure, then air will want to move from the outside into the lungs. Now, we've talked about a lot, so I'm just going to describe one more thing. We can think of this space in between the visceral and parietal pleura. We have this space right here, right? That space typically has somewhere around -3 to -4 millimeters of mercury is the pressure of it. In that space, that negative pressure is important for the concept of helping the lungs to exhale, right? Because when we inhale, remember, when we inhale, we have this negative pressure volume. When we exhale, we're increasing the pressure. So when you inhale, your lung volume increases, so the total volume of the lungs increase. We are decreasing surface tension when that happens. The radius of the lungs is becoming much larger, so pressure decreases, right? When we exhale, then as we exhale, we go back to the tension will increase, the radius becomes smaller, we get a larger pressure in the lungs. And so the negative pressure is important in that space in order to allow for the lungs to inspire. So let me draw a graph here. So one quick thing before we move on. Let's say we have something that comes along and it tears an area of this parietal pleura. In this area here, the parietal pleura of the lungs is like butted up right next to the rib cage. So that's what I'm drawing right here, like little ribs, right? Let's say we had something that comes and punctures it. We get a cut, we get a gash, something. And so this area here, since this is a negative pressure, we're going to start actually introducing air coming in. And as air comes in, it disrupts that negative pressure of the pleura. This is what we call pneumothorax. Air will come in, disrupt that negative pressure, making it more positive, and now it becomes significantly harder for the lungs to breathe. And so when we have a pneumothorax, the lungs, air is going to start leaking from the lungs into the surrounding pleura, and that is going to basically just weaken our power to breathe. And this is a medical emergency. Somebody with a pneumothorax needs to be treated immediately, because it will basically just disrupt. So it'll allow air to enter into the pleural cavity during inspiration, but it can't exit it. So basically, we'll start to compress. So air is entering in here. We start to compress this, the visceral pleura, even further inwards too. That begins to compress whenever we have a pneumothorax, which will compress our alveolus, which then can lead to a collapsed lung very quickly. And when we collapse our lungs, and it's extremely hard to breathe, and it's serious. So this has to be treated immediately, or else the lungs will collapse, and it just becomes extremely hard to breathe, and that can lead to death if it's very serious. And so we've talked about a lot so far. Let us take a step back from talking about the inspiration and exhalation that occurs in the lungs through negative pressure ventilation. And let's move on to another topic. This is alveolar gas, the alveolar gas equation. So let me write it up real quick. The alveolar gas equation is the PaO2 is equal to FiO2 times ATM minus H2O. That subtracted by CO2 divided by R. So really quickly, let me label what each of these things means, and then let me talk about a couple of things that are happening within gas exchange that will help us to understand this equation a little bit better. So let me label these parts. Fi is the fraction of inspired oxygen, so oxygen breathed in, right? This here, ATM, this is always our atmospheric pressure. Water has a pressure as well, so this is going to be our pressure of water. Here, this is our pressure of CO2. And then R. R is an average. Typically, R is equal to... So, the name for this, we're going to call it the respiratory exchange ratio. You can also call it the respiratory quotient. That's fine as well. I'm just going to call it the respiratory exchange ratio. It makes a little bit more sense when I'm describing the process of what's happening. But typically you calculate R if you have a balanced equation of CO2 and O2 gas being exchanged within a balanced equation. You just take the balanced equation, the mole fractions that are in front of those two values, and you take them and divide them to figure out your respiratory quotient. This typically has an average value of about 0.85. Obviously, it's different in different scenarios, depending on the fraction of CO2 and O2 we have, but for now, we're going to call that an average of 0.85. So, what is PaO2 actually calculating? That's a question that you might be having right now. And so, let us describe a process that's occurring in the lungs And then we'll talk about what the PaO2 is actually describing, what we're trying to calculate. So, in your lungs, we have two primary gases that get exchanged constantly, right? Those two primary gases are O2 and CO2. So these blue dots, let's just say these are O2 molecules here. Typically, a pressure of oxygen within the alveolus stands around 101 millimeters of mercury. So this is O2. Veins return to the lungs to become oxygenated, and so here this blue here, this isn't, sorry, my bad, this is an artery coming to the lungs to become oxygenated with blood, right? And then so this would be a pulmonary artery on this side. On this red side here, this would be a pulmonary vein returning blood back to the heart. They're backwards there. But oxygen on the arterial side has a pressure of about 40 typically. It moves, so this oxygen is going to move through the bloodstream this way. The blood will move this way. And as it reaches the lungs can do gas exchange, meaning oxygen can move out of the lungs and into the bloodstream here. And as that happens, the blood becomes more oxygenated, and we move up to a partial pressure of oxygen being about 100, around 100, 101, in the venous side of the pulmonary arteries, which will now take oxygen and transport it to different tissues in the body. Bring it back to the heart will distribute it, right? So now let's talk about our pressure of carbon dioxide on this side. We're going to have less carbon dioxide in the blood. It's around 40. Over here, we're going to have more carbon dioxide in the blood, and it's around 100 on this side. So PCO2. We're reversing roles here. So carbon dioxide within the lung itself doesn't have a very high pressure. It is around 40 here. And remember, typically we want to go from a high pressure to here we'll have oxygen leaving the lungs, CO2 leaving the bloodstream to go back into the lungs and get released out. So CO2 goes out here. Oxygen comes in. So going back to this alveolar gas exchange equation, the PaO2, it represents the partial pressure of oxygen in the alveolus. This is super important because if we want oxygen to go from the alveolus into the bloodstream, we want that partial pressure to be around 100, like we were saying earlier, right? Normal range is give or take 100. If we were to go above 100 or below 100, if we're going above, we are in hyperoxemic conditions, which is not good. If we go below that 100, significantly below it, then we are in hypooxemic conditions, which is not good. Typically, if the PaO2 decreases, so let me write this off to the side here. If PaO2 decreases, this means there is insufficient O2 going into the blood. We can suspect conditions like asthma, we can suspect things like CPOD, which is a chronic obstructive pulmonary disease, right? Chronic obstructive pulmonary disease. And yeah, so we can start suspecting, okay, so if this patient that comes into my office has a PaO2 that is pretty low, and we can predict the PaO2 by getting these other values up here, right? We can say, all right, well, this patient probably has an underlying condition that doesn't allow them to breathe in oxygen very efficiently, or doesn't allow them to, like asthma, or chronic obstructive pulmonary disease, or somewhere around those lines. If we have an increased PaO2, that just basically means that we are way over the normal range for our PaO2, which is about 100. This could be up to 120 or more. And typically, if we have this happening for extensive periods of time, this can be toxic to the body. We might want to increase that in certain situations. Like if we might want to be giving the patient more oxygen in certain situations, but we don't want it to become to the point where it's toxic to the body and lethal, and which can have a negative effect on the lungs eventually. So if we're in the hospital giving somebody oxygen in the ICU or somewhere else, we need to be careful about like making sure we're keeping those oxygen levels at a steady rate, which they need, and not giving them too much to where it can become a toxic level to them. So now I wanted to switch gears one more time, and now let's go on to talk about the last concept I'll talk about in this video, and this is going to be hemoglobin. So, really quickly, hemoglobin is used to help this. It helps to transport oxygen and sometimes carbon dioxide through the bloodstream. So we have our lungs here, right? So alveolus is doing gas exchange. We meet with the bloodstream. here in our bloodstream, it's very rich and abundant in our red blood cells, which are hemoglobin. And so oxygen has to get from the lungs into the bloodstream first. So let me move my hemoglobin molecule right there. That's fine. Oxygen has to get from the lungs into the bloodstream first. So as oxygen diffuses from the lungs into the bloodstream, it now can bind to hemoglobin. And it binds to hemoglobin, and we transport oxygen primarily through hemoglobin. And so hemoglobin typically gets up to it's a really high number. About 2% of the oxygen will stay in the blood, and about 98% of the oxygen that comes from gas exchange will be bound to hemoglobin. And so CO2 can also do gas exchange with hemoglobin through our bicarbonate system. So let me move this out of the way. Talking about oxygen. Alright. So let me draw this with green. So bicarbonate carries the bicarbonate system is water and CO2. So water is a big plasma component, right? Blood plasma component. When water combines with CO2, and CO2 combines with water, it makes two products, bicarbonate and hydrogen ions. So if we have bicarbonate in the bloodstream, typically this will in the bloodstream convert over to this. We can take that bicarbonate, move it into red blood cells, and we can convert it over to CO2. Let's convert it over to CO2. We can attach it to hemoglobin, or we can kick it out of the bloodstream so that when we get over here, we can diffuse that CO2 over into the lungs. And so hemoglobin is basically the taxi that shuttles CO2 and oxygen throughout the body. Now, let's talk a little bit about hemoglobin, and let's talk about some of its uses and how important it is. So one thing that hemoglobin does is when this red blood cell has made its journey down to be further down the bloodstream, not in the same spot. I'm just going to draw this right here for timing purposes. But when hemoglobin's made it to its destination, right? Move that down just a tad bit. Hemoglobin has made it to a tissue cell. Now, that hemoglobin in the red blood cell can take the oxygen that was bound to it. It's going to take that oxygen and is going to dump it into the tissue. So oxygen comes in, boom, right? So what happens is kicks oxygen out into the bloodstream. Oxygen diffuses across the bloodstream into the tissue, and boom, we have it there. Now, CO2 in the tissues can come into the bloodstream. When they diffuse into the bloodstream, they become bicarbonate. When they become bicarbonate, they can move into here. And then once they've moved into there, they can be converted back into CO2. And CO2 can be stuck onto hemoglobin, right? And then that hemoglobin can transport the CO2 back up to back up to the lungs, and the lungs can dispel CO2 out, right? So this is constantly happening in our body. Hemoglobin is moving oxygen and CO2 back and forth. Hemoglobin is found in two states. So we have the T state of hemoglobin. T represents taut. And we have the R state of hemoglobin. R representing relaxed. In the R state, let's talk about that first. Hemoglobin has something called a porphyrin ring. Let me just show you a picture of what that looks like really quickly. So, hemoglobin, porphyrin ring. So, I like this picture. So, if you see that picture there, hemoglobin has this ring structure around it, right? That ring has an iron in the center, and when that iron is relaxed, oxygen can bind to it. Now, let me show you what the T state versus the R state would look. So that picture was showing the R state. Here we go. Here's a good picture. So, actually I don't like that. Let me see if I can find a better one. It's kind of blurry, but I like this one. So if you notice here, in the T state, so if you notice this brown ball right here, that is iron. And when iron is in the center and relaxed, the ring hasn't moved or anything, oxygen can bind. This right here, this is what we call puckering of the porphyrin ring. And this is what causes the T state. We have several amino acids here. The amino acid that is right here is our distal histidine. And this histidine right here, that little pentagon ring there, is pulling on iron, and it pulls it down and creates it taut, right? So it moves it down a couple of angstroms. Honestly, this isn't very much, but when it moves it down, it closes. So see this little hole right up here? The protein has this hole where oxygen can fit in the R state. So oxygen binds in the R state when it's relaxed. The T state, when it's taut, that hole closes up. It's really hard for oxygen to fit in there now. So oxygen can't fit very well. And so that's a little visual description of the T versus R state of hemoglobin. Now let's come back here. in the R state, hemoglobin the porphyrin ring is relaxed. And that means that oxygen can bind to the iron core, right? In the T state, the porphyrin ring is not relaxed. It is taut, meaning tight, right? Pulled down. This causes puckering of the ring. And here, oxygen cannot bind to iron. Now, there's a couple of things that cause this T state to occur. So let me talk about that. So things that cause the T state of hemoglobin. Sorry, I can't spell that. Globin. There we go. The first thing that causes the T state is what we call high levels of hydrogen ions. You can have high levels of CO2, increased temperatures in the body, and increased levels of 2,3-bisphosphoglycerate. Glycolysis produces the molecule of 1,3-bisphosphoglycerate. There's an enzyme that can take that called a mutuase enzyme. It converts 1,3-bisphosphoglycerate into 2,3-bisphosphoglycerate. So a way that 2,3-bisphosphoglycerate causes a T state of hemoglobin is this is a negatively charged it's a negatively charged molecule. This negatively charged molecule, 2,3-bisphosphoglycerate, can go into the hemoglobin has a positive pocket, and when 2,3-bisphosphoglycerate has its negative charge, it can go bind to the positive pocket of hemoglobin. When this happens, it creates a pulling on iron, that porphyrin ring, iron, right? Pulls it down, forms a salt bridge, and this brings hemoglobin into the T state. Increased levels of CO2 or hydrogen just means that we typically have more carbon dioxide bound to hemoglobin or bicarbonate in our bloodstream, which will allow conversion to CO2. So those things will be bound to hemoglobin, and when they're bound, it's in the T state. Increased temperature. This creates the T state for hemoglobin by just increasing just the amount of kinetic energy it has. And so it's not going to be relaxed anymore. It's going to be taut when kinetic energy is increased. The very last thing that I want to talk about tonight is the hemoglobin dissociation curve. And so we talked about the R state and T state and things that cause a T state of hemoglobin. Remember that in the R state, that's when oxygen binds. In the T state, oxygen cannot bind. But let's look at the hemoglobin saturation curve. right? So here, oops. Let's say on my x-axis here, just gonna make up some values that we can look at. So 20, 40, 60, 80, 100. So this is our resting cell. Its PO2 value in millimeters of mercury. And then over here on this side, let's associate some values here. 10. These values are the percent of hemoglobin that is saturated with oxygen. Or hemoglobin saturation. We can call that the hemoglobin saturation percentage, referring to oxygen, right? So some important values. I just want to be able to graph out kind of correct. So I'm going to do this for myself. So that's our saturation curve there. As our pressure of oxygen increases, the saturation of hemoglobin with oxygen increases as well, which makes sense, right? That's what normally happens. When hemoglobin is in the R state, this is what we call a left shift of the curve. When we have a left shift of the hemoglobin saturation curve, hemoglobin is in the R state. In the R state, it more readily binds oxygen, so we're going to have a higher percentage of oxygen bound to hemoglobin there, right? We can also have a right shift to the curve. Right shift to the curve is when hemoglobin is in the T state. In the T states, oxygen does not bind as well to hemoglobin, and so we'll have a decrease in the amount of oxygen saturated to hemoglobin. So, just really quickly to end this video, just want to do a brief recap. Our lungs, they work through a negative pressure ventilation system, right? We discussed how that worked. We discussed how gas exchange works through the gas exchange equation. And we talked about the role of hemoglobin and what it does and how it helps to shuttle carbon dioxide and oxygen throughout the body. I hope you all found this video helpful. Thanks for listening.